And we're on.
Well, welcome, everyone, to another session of conversations about COVID-19 and more from the McGill Office for Science and Society. And for those of you who may not be familiar with us, our office was founded 20 years ago with a mandate to separate sense from nonsense, fact from folly, and to make sure that the public is up to date on what is happening in the world of science. And we deal with all sorts of issues, from cosmetics to food additives to medications, plastics, everything that is of interest to the public. And of course, these days, there's nothing of greater interest than COVID-19, and very difficult to find anything else to talk about. It is the topic of conversation, and that's why we're having these conversations. Behind the scenes, monitoring everything and making sure that your questions get answered, and having her finger on all the right buttons most of the time, is Emily Shore. Also joining us is my colleague Jonathan Jarry, and his background is molecular biology, so he's very up to date on everything to do with COVID-19. And also joining us today, as she has done several times before, is Dr. Debbie Schwartz, who I think I have known since the moment that she was born. And she's an emergency room physician and works at a hospital here in Montreal, and of course is at the front line treating COVID patients. And obviously, we are going to start our discussion about masks. Why not, right? So Debbie, you're wearing a mask even though we are not transmitting anything through the airwaves. Why?
Okay. So firstly, I clearly don't need to be wearing a mask, and it's basically to prove a point. I mean, I'm sitting here all by myself. So I absolutely do not need to be wearing a mask. So that's something that I want to bring up is that, if you're by yourself, if you're in your car, for example, you don't need to wear a mask. The reason why you would need to wear a mask is really if you're in a crowded place with multiple other people, and you want to protect the other people from yourself. If you happen to be symptomatic, or, well, if you're symptomatic, you should not be going into a crowded place, but if you're an asymptomatic spreader. So I did wear the mask just because I want to show you what it is, since a lot of people are asking how you wear a mask and the techniques behind it. So basically, this is called a procedural mask. This is a surgical mask. So you've got the two loops here and a couple of layers of tissue here. And when you're putting on the mask, the important thing is that you don't actually touch the mask itself, but you're only touching the loops around the sides. As soon as you're touching it, you are contaminating it. So you basically just put it on like so and wrap it around your ears. And there's a little bendy part at the top that you kind of pinch around your nose to tighten it. And if it's a little bit loose, you can turn the loops like this and wrap them like that. And then the other important thing is the way that you take it off. You should be taking it off by the ear loops, removing it like that, not on your chin. You don't want to protect your chin. Your chin doesn't need to stay safe. Your ear doesn't need to stay safe either. So take it off like that, throw it in the garbage. It's finished, this one. This one is disposable. And then the ones that are not disposable, you would want to do the same thing and then basically put it onto a surface where you're not going to be touching the outer part of it. And you should definitely buy a couple of them so that you can wash them and interchange between them.
I just want to reiterate, because I also had the same question. So basically, with the non-disposable masks, like the cloth masks, as soon as everything starts reopening and we kind of start going out to more stores and back home and work and back home for some of us, we should probably be having more than one mask on us in our purse, in our bag or whatever. So we go out to the store, we wear it, we come home, we take it off, we put it in the laundry. Oh no, you forgot to do an errand. You're going back out again. You put on another mask, you do that. Right?
Yeah, I mean, I think that, obviously I'm in a different situation when I'm working with patients. When you're out, I would say with a cloth mask, I mean, as long as you're not handling the outer part of the mask and you just take it off by the loops, I would say that you're probably okay. Hand hygiene is crucial. So keep a hand sanitizer in your car. Wash your hands before you go to take it off, and then wash your hands again after you've taken it off.
I see people out walking and bicycling with masks. for which there is no scientific evidence whatsoever. You do not catch this disease by walking by someone for a second. We are now getting pretty good idea of exactly how this thing is transmitted. Yes, it can be transmitted through the air, but just like we say with toxicity, that it's a question of hazard and exposure, that's how we evaluate risk. Here it is also a question of the hazard and exposure. The virus, of course, does present a hazard, but you need a certain viral load in order to be infected, and you need exposure for a certain amount of time. Now, of course, no one is quite sure how long that time is, but it is not a few seconds. So walking by someone on the street is not the way that you're going to catch this virus. Indoors is the real problem. That's where it spreads. And that's why we're seeing all of the spread in the old age homes. We're seeing it in the meat packing places because there are people work next to each other, breathing the same air for hours at a time.
Right.
So I think one has to be, quite reasonable here and not go overboard and think that when you're walking on the street, everyone who walks by you is a lethal hazard.
But they have
anyway.
We have
Today, breaking news about children and this novel infection that is being found, which has some resemblance to Kawasaki disease, although it's not exactly the same. And it seems to affect many organs. It's a multi-system inflammatory disease, and that's what is now being called. So Debbie, maybe you can just give us a little bit background here on what Kawasaki disease is and what doctors are looking for in terms of symptoms, and what the chance is that this is really connected to the virus.
Yeah. So, I agree. It's very relevant to talk about pediatric presentations of COVID. Up until basically a couple of, weeks ago, it has seemed like COVID has not really had much of an effect on children and they have generally been presenting as asymptomatic or mildly symptomatic, maybe with some mild fever, cough, some gastrointestinal complaints. But within the past couple of days, there was a report that was sent out from the National Health Service in England that basically said that over the last 3 weeks, there had been an apparent rise in children of all ages with multi-system inflammatory states that required intensive care in both London and then across the UK, and that these were sharing common features with toxic shock syndrome and atypical Kawasaki. So this is obviously breaking news for us. So what is Kawasaki? So typical Kawasaki, it's actually one of the most common vasculitides of childhood. So vasculitis, it's an inflammation of vessels. And Kawasaki presents with fever associated with some other findings. Fever is 5 days in order to diagnose it. So it is a clinical diagnosis. There's no diagnostic test for it. So it's 5 days of fever plus 4 out of 5 of the classic findings of rash, conjunctivitis in both of the eyes. That's non-exudative, which means that there's no discharge coming out. Redness and swelling of the hands and the feet. Mucous membrane changes. So that would be something that we call strawberry tongue, which is basically a very prominent red tongue, but even cracked lips can fit that criteria. And then cervical lymphadenopathy greater than 1.5 centimeters. So that's basically the way that we diagnose Kawasaki. Generally, Kawasaki is a self-limited disease. The inflammation will generally last for about 12 days. It's really more the complications of Kawasaki that are concerning. And those are coronary artery aneurysm, which can lead to heart failure, heart attack, and that obviously leads to significant morbidity and mortality if it's not treated properly and in time. So the treatment for Kawasaki is intravenous immunoglobulin with aspirin. And then follow baseline cardiac echo, and then follow up a cardiac echo. So these children get followed up for a long time. We don't really know what the cause of Kawasaki is. So this is kind of it kind of seems to be the theme with COVID, actually. So some ideas of what the etiology is an inflammatory response, or it could be an infectious trigger. So actually, Kawasaki has actually been previously linked with other epidemics in Japan. And then it can also another possible etiology is genetics, because we see it more commonly in Asians. So the cases that have come out of the UK, though, they seem to be atypical. So what that means is that the children are presenting with fever, and then only 2 or 3 of those findings that I mentioned, the rash, the conjunctivitis, the swelling of the hands and feet, the changes of the mucous membrane, and the cervical lymphadenopathy. So they're all case reports. I think that it's too early to tell if this is of some kind of importance. Here in Montreal, we have not had any cases to date at Saint Justine or at the Children's. The case reports that came out of the UK, I mean, the numbers were very small. So we're looking at 12 kids in the UK that required ICU, and then 20 cases in Italy over a 1-month period. But this is for sure a dramatic increase in the incidence when you compare the incidence of Kawasaki over the past 5 years in Italy. I had read somewhere that they had 19 cases over 5 years, and then 10 cases over a period of 3 weeks. So this looks interesting for sure, but we don't have enough information to hang our hat on right now.
Let me bring Jonathan in here, because there's so much talk about testing, and this is the key thing: is testing people to, for example, in this case, whether these kids have a test that demonstrates that they've been exposed to the virus, and so there's a lot of talk about the serological tests, testing for antibodies. What does that really involve?
Yeah, so as you mentioned, I just read there's an article in The Lancet about those cases from Italy that had this Kawasaki-like syndrome following exposure to the coronavirus. And so the start of their symptoms was about between days 4 and 8 of having a fever. And so by the time you get them tested, the typical test that we're familiar with here in Quebec now, with the swab going way back up your nose to extract the genetic material of the virus, that test may no longer work, because the genetic material from the virus may not hang around very long. So then you get into the other type of diagnostic test, which is the antibody test. And that is what they use. I mean, they also use the PCR test, the genetic material test that they use, but they also use the antibody test. Here in Canada, there's only one antibody test kit that has been approved so far. There have been a lot of applications. In the United States, they applied, they essentially gave, it's not even an emergency use authorization, it's just like a blanket, sure, go ahead and use it kind of approval that the FDA gave them. And now they've kind of rolled it back, and they're trying to go back and say, well, hold on a minute, let's make sure that these tests actually work. Whereas here, Health Canada from the start was like, well, no, let's give me, if you're the company, give me proof that your kit works before we're going to approve it. And so the one kit that is approved right now is by Diasorin. It's called the Liaison SARS-CoV-2 S1 S2 IgG test. And IgG is the most common type of antibody found in the blood. And so the way that this works is that you essentially take blood from somebody, and what the kit has is has these magnetic beads, and on the beads are parts of the spike protein from the coronavirus. And if you have antibodies against these spike proteins, then there will be a binding, and that can be detected by the kit. They are reporting very high sensitivity and very high specificity of the test, which is good. Those are numbers from the company. I would love to see an independent evaluation of that, but this was good enough for Health Canada to allow for the sale of this particular antibody kit. But that's it. That's for now. It's the only one.
Not cheap, as I understand.
I haven't seen the price. Have you seen it?
$200.
For how many samples?
Oh no! The charge to the patient is $200.
I see. Wow. Okay.
Yeah.
Well, that's not insignificant, although I suspect people will be willing to pay it. There's also the question of false negatives, false positives. with all of these tests, including with the PCR test.
Of course.
They just had, actually on the news tonight, a report of a physician who had 4 negative tests in sequence and yet came down with the disease and is on a ventilator after four times being tested and coming up negative. So there's a lot of stuff, left to be desired with these tests.
Yeah, I believe it because I'm seeing it with my own 2 eyes. I mean, you see a patient in the ER who's classic COVID, who has the classic chest X-ray or CT findings, and the COVID test comes back negative. But I mean, fortunately, we're not buying one negative test if the symptoms are correlating with the disease, and we're repeating it. And I have seen them turn positive when repeated 24 hours later.
But what about after Dr. David Zlotnick was here a few weeks ago, and they said in Israel that after you do your quarantine in 14 days after you're positive, they're not allowed back. Israelis are not allowed back out unless they have two negative tests. So do we have anything like that here? Or I heard that some people cannot even get tested to begin with. So is there a follow-up with patients after, or can someone just go to the store and go buy a loaf of bread after their 14 days if they feel okay?
So I do agree that Israel has taken, not surprisingly, a really impressive stance with COVID. They reacted early and they put measures in place very, very quickly. So that's where I think that they have. That's why they are where they are right now, and they're able to return to. They're able to start the deconfinement process. We do have the same thing in place for healthcare workers. So you're not allowed to return to work unless you have two negative tests. For the general population, testing has opened up. So generally now, whereas before we started out only testing symptomatic patients, and then there was a period of time where we couldn't get enough tests to even test patients that were symptomatic, and we were making clinical diagnoses. And now we're back to testing symptomatic and even some asymptomatic, more if you've had a close contact, I would say. So, but we are testing a lot more, and that I think that is really what's important. If we're going to start the deconfinement process, it's going to be about, as Dr. Zlotnick talked about, testing and contact tracing. That's what's so important. And so that's what we need to ramp up. And we are ramping that up. So I
see that they're outfitting buses as testing centers, and they're going to move around the city. And I know my understanding is that you can just go and be tested.
Yeah, there's mobile units set up in various locations in the city, and we still have a screening test in our setup at our hospital where we are freely screening. So patients are coming and they get screened in the tent. If the nurse who's doing the test is concerned about them in any way, she'll pass them along to the emergency room, but they send home many patients directly from the tent.
But let's say this bus testing thing works and people go and get tested. So you go and you have a negative test. Well, what does that really mean? Because as we see, you could go the next day and be positive.
Yeah, I mean, definitely, I think that there is a false sense of reassurance that goes along with a lot of tests. I could think of many tests that are similar in medicine, but again, I mean, I think that the false negative rate right now, the latest I heard was about 6%. So, I mean, if you're negative and you're
that's better than
asymptomatic,
that's better than the false positive rate that I heard in the States anyway, which was 16%.
Which are false positive?
Yeah. Sorry, for the antibodies. For the antibody testing.
I'm not talking about the
no, but that's good.
Test.
Right. But that's significantly lower anyway, like that.
So I actually think that it's important to make a clarification because
there's two tests.
There are two tests, exactly. So what I'm referring to is the PCR test, which is the nasopharyngeal aspirate.
The diagnostic one.
Yes, so that's the one where the Q-tip is put into the nose and takes a sample from the nose. So the antibody test it's a blood test, and the blood test, as of now, from my understanding, is not particularly good. It's not particularly useful.
There are many kits out there. That's the thing, and some of the kits in the U.S. have terrible performances. But the one that's been approved by Health Canada, according again to the user's guide put out by the company, the specificity and the sensitivity is very, very high. Now, those also depend on when you're testing the patient. Because if you're testing the patient at the beginning of the illness, then it's not going to be as good because you haven't made enough antibodies for them to be detected. So that's also dependent on when you test a person.
So what you would recommend it? The serology?
I'm not a doctor. I'm not recommending anything. I'm just saying.
No,
looking at the specificity and the sensitivity of the test that has been released by this one company that has a Health Canada approval, the numbers are very, very high.
What are the sensitivities and specificities?
I will give them to you in a second.
Because I do have lots of patients asking me about this, and I understand it. I mean, it makes sense. Obviously, people want to know if they have been exposed to COVID. I mean, I think that we're still not 100% certain whether you can be infected twice, but I'd say that the chances are, if you have antibodies, your body doesn't develop, this huge revved up immune response that's going to land you in the ICU.
Yeah. So, for example, if it's been at least 15 days since the onset of symptoms, in 39 samples that they tested, the sensitivity was 97.4%. And the specificity for routine laboratory tests, and that's 90 samples, that was 98.9%.
Those are good numbers, except that the samples are not good numbers.
Yeah.
But also, you make a good point, Jonathan, because the antibodies take some time to develop. But if one gets tested at the beginning phase, then they may differ than 14 or 15 days after. But why would one even get tested for antibodies at the beginning? Oh, you mean without displaying symptoms? If they weren't, this is not like a patient in the hospital that would get an antibody test.
No, but I suspect that the company needed to show these things. And so, for example, if in samples that were taken from patients who had symptoms for less than or equal to 5 days, the sensitivity was down to 25%. So it was terrible. But it goes up the longer you've had the symptoms because you're making more and more antibodies, and so you're detecting them more easily.
Yeah, so you sort of have that inverse relationship between the serology and the PCR test, because as you go,
as one curve goes down, the PCR curve, then the antibody curve goes up.
Exactly. Yeah. So that's something to bear in mind as well. Depending on what point in time you are, you may choose one test over the other. But currently, the only recommended test is the PCR diagnostic test, which is the nasopharyngeal aspirate. Really uncomfortable one.
And of course, we know that the U.S. has the best tests, the most beautiful tests, and they are testing the most people.
They have the most tests, I will say that. They have a lot of kits out there.
Yeah. So, Jonathan, I mean, in the last couple of days, we've seen Trump pick a fight with Dr. Fauci, which is so bizarre that it is beyond words, where, on one hand, we have an expert who's been leading scientific figure for 40 years. On the other hand, we have someone who has no idea what he's talking about. And we have the situation now where basically Dr. Fauci is losing out to ignorance. And Trump is taking sides with the people who are demonstrating to have everything opened up. And he wants all the schools to open up in spite of the most recent warnings about this Kawasaki-like disease. So,
look, you said bizarre. I would not say bizarre. I would say this is part of Trump's MO. I mean, this is what he does. If an expert disagrees with them, then he goes against the expert. I mean, he's worried about the economy. He's worried about his reelection. I mean, he's not concerned about scientific validity of anything that he says or anything that he does. I mean, that's shouldn't be surprising at this point. It's just Trump.
No, Trump is impervious to facts.
Yeah, pretty much.
Yeah. All right, let's leave that alone.
So we have can I ask some more questions? Because people are asking about masks, because as things are reopening, more masks are being worn. So There's two questions, and one says, what about the eyes? Because the masks, cover nose to, chin, but the the virus does enter through the eyes. So what does the mask even do for that?
The mask doesn't address the eyes. Obviously, you're not going to walk around with a mask over your eyes. You could wear glasses if you want. Sunglasses are a good option. But again, I mean, the idea is that you're not getting close enough to people to have them spitting into your face or, speaking and moistly, as Justin Trudeau
Speaking
says.
moistly, exactly, yeah.
But if you really want to be secure, you could wear sunglasses. You could wear a visor if you want, although I really don't think that that's necessary. But yeah, absolutely, the mask will not protect your eyes.
I have a question that I know is for me, but I know other people also share it. There's a lot of, fashion companies that are now making masks and doing great things and prints and trying to make them an accessory, basically. But how does one make sure that the masks that people, these solo companies, people are doing masks, what should they be looking for when it's not just one piece of cloth, right? There's a little bit more to it, I think.
So generally, I actually don't think so. I think that any face covering will do. A scarf will do. A little bit more cloth will, I mean, in theory, potentially protect you. Offer a little bit more protection. But the goal is really to keep your respiratory droplets in, and I think that a scarf does that effectively. So I wouldn't be too concerned. I would choose, a mask that you like, a mask that feels comfortable for you. It should fit you snugly, though. It shouldn't be loose. And again, you should not be wearing it on your chin or on your ear. It should really be covering your mouth and your nose, and you should not be touching it. And just wait until you see the mask that I got for Dr. Joe.
I will add one word, one note about comfort.
Sorry, it has ducks on it.
I will add one note about comfort, which is that I think what we might be finding out is that companies that have a lot of experience making masks have figured out the best materials, the best elasticity for the loops to make the mask as comfortable as possible. Now everybody's making masks. I bought some reusable masks, and they are well made in one sense, but at the same time, they're really pulling my ears down because the loops are not well made enough. And so that might be the issue, that some masks may be a bit more comfortable to wear than others. But as Debbie said, I mean, if it is covering from the bridge of your nose down to under your chin, and it's not made of cheesecloth, you should be fine.
And I will add that if it does bother your ears, there actually are ear savers as well that you can wear, that are little pieces of plastic that go in the back of your head, and you could attach the loops to it. So that might save your ears.
All these are all new business ventures for people.
Yeah. Hold up the mask for a second. Hold the mask you have. There's an awful lot of technology in that mask. And for those people who say that they don't want any plastic in their lives, and of course I've had arguments about that, this mask is ingeniously made of several different kinds of plastics. The main one is polypropylene. And if it weren't for plastics, we would not have those masks. I'd just like to throw that in to all the plastic haters and who say that we should get rid of all plastics in our life, which of course is absurd.
So we have a few more here. One more. Okay, in Canada here we have a long weekend coming up, and in the States there will be one next week. And as the weather is improving, people are going out. And you could see it. You could see in all the parks around. There are clusters of people that were never congregating in those particular parks before. So this one, the question says, what about multiple people and kids gathering in backyards or parks? Is this a worry for adjacent neighbors? I mean, aside from the noise, I assume she means in terms of virus spreading.
Okay, so this kind of brings me back to a little bit of a hint of the conversation that I had started about schools reopening. So I think I will just preface this by saying that I am not a public health expert. I am a doctor, I'm a mother, and I'll give you my, my opinion. And at the end of the day, all of these are opinions. I think that moving forward, we're going to be seeing a lot of what we have labeled quarantine fatigue. And I think that this is really important to address because we cannot continue in this social isolation permanently. It is detrimental to our society. It is detrimental to our children. It is on so many levels. I think that there's so much collateral damage from COVID. So now that schools, as of today, have officially declared that they will not be reopening until September 1st, my personal opinion is that children need something. They need to outside. So I think that this was a great segue because you mentioned the backyard. So I think that outside to interact with other people, in my opinion, is within reason and within a small bubble of people. I feel that is okay. Do I think it's a risk to your neighbors? No, I don't. Your neighbors are hopefully more than 6 feet away if you're hanging out in your backyard. I think that it is more important at this point to address the needs of ourselves as social beings. And I'm not saying to go and hang out in a pack in the park, because I have seen teenagers doing that, and I do not condone that at all. But I do think that there is a medium in the middle that we can strive for within reason.
Well, as a non-social being, let me add my opinion to this. I think if you are sitting out in your backyard doing whatever it is that you do in your backyard and your neighbor is in their backyard, I would say the chance of this virus being transmitted is zero. So I would have no concern about that. I have very little concern about viral transmission outdoors. I think it's very unlikely given how the air circulates and the viral load that you need. It is indoor that you really have to think about wearing a mask.
And anyway, I think that's why it's so important to do something, going forwards. I think that, the importance of day camps or some kind of structured activity for children is going to be so important moving forward.
Except I have a question because I 100% agree with you, and there has to be some way to kind of move out of this rut a little bit to make this is our new normal right now, at least. So I agree with you. However, there's also the balancing, I feel, in terms of like the slight trauma that people felt. And I know that you said that you would send your kids to school when they were going to be reopened. And I have other friends, and I'm sure you do too, that we're not going to do that. More so because the school that every child wants to go back to no longer exists, or not right now. And so, having to go into a schoolyard or go into a school and have your teacher wearing a face shield or picking up the 2-year-olds because it's a preschool and the parents can't, go and they have to wear layers. I mean, it is crazy what has to be implemented, but that is what has to happen. So there's also a mental struggle there as well. I think that it's not the school the kids think of. They want to go back to their old school like we want to go back to our old lives. We just know better right now.
Yes, but whether we go back to school, well, at this point we're only going back in September, but that will be a problem in September as well. The teachers will be wearing PPE in September as well. And our kids will not be returning to school as they knew it. And our lives are not going to be returning to the way that we know it. So I think we have to learn a way to live with COVID in our lives, right, and take a few inches forwards because, again, I mean, yes, we are at our peak right now, and so we are still nowhere near ready for dramatic deconfinement. But I think that I'm not convinced still that children are the super spreaders that some people feel them to be. I'm not convinced about that. I've just read too many reports stating otherwise, and I don't think that's the answer is to, continue to shelter our children. I think that they're suffering tremendously. And I think people are suffering in general. I mean, I can tell you that the number of patients that I speak to on the phone when I'm doing my family medicine visits, the number of elderly people, who live alone, the depression, the anxiety. I mean, that's the trauma, and we're going to be suffering from this post-traumatic stress disorder for a long time coming. And I think that we need to start figuring out how to deal with it and how to address it. So, I don't think that keeping people in their bubbles the way that they are now is the answer.
I mean, as someone says here, and she's right, they're right, it's about controlling the virus and not stopping it right now. But that also kind of leads into another question here that we got, asking about, different strains of the virus, and is there any evidence showing the different strains? Can it morph?
Jonathan.
Well, again, the word strain means different things to different people, and I think to many clinicians and to the public in general, two different strains of the virus means that they behave differently, right? That one might be deadlier than the other. But to molecular biologists, a strain is just a version of the virus that has at least one mutation compared to another one. And in that case, there are hundreds of strains, well, at the very least, well over 100 strains of this coronavirus. But, once in a while, there is a story that pops up and says, oh, scientists have discovered a new strain of the virus. And that study always gets a lot of criticism, a lot of pushback from scientists. So if you're worried, like, is there another strain of this coronavirus that is deadlier, that is behaving differently? The answer so far is no. And the virus is relatively genetically stable. Is it possible that in the future the virus might mutate randomly in a way that will make it, harder for us to treat it when we do have, specific treatments, or that will impair any vaccine that is under development? That's a possibility, but it's not something that we've seen so far.
Well, as Jonathan says, different strains mean that you have different segments of the DNA being different in the viruses, but it depends on where that segment is located on the DNA, that is, which gene has mutated. And it may be a sequence on the gene that is totally irrelevant in terms of the infectivity of this virus, or how it reproduces in the body. On the other hand, if you have a mutation somewhere in the spike protein, that may be a significant difference.
It may be, or it may not even be. And yeah. I'll give a good example. Because when we hear mutations, we always think, oh, something bad is happening. That's not the case. Most mutations are neutral; they have no impact whatsoever. And part of the reason for that is that the genetic code, whether it's DNA or RNA, is read in groups of 3. And each of these 3 in a row will code for a particular building block of the protein that is being made. That's the whole purpose behind this genetic code. And there are redundancies in the code. And so there are a lot of instances where that third base could be any one of them, and it would still code for the same building block of the protein. So if you do happen to have a mutation in the virus at that third position, it may very well be that the protein that is being made from that gene is exactly the same. So there are all of these redundancies at play there that make it so that even when you find a mutation, it does not mean that it has a deleterious effect. In many cases, it's completely neutral.
Or it can even be positive. I mean, there are many mutations that have had positive effects. If you look at some of the mutations that we see in food, there are positive things, like the pink grapefruit or red grapefruit is brought about by a positive mutation. I don't think that this coronavirus is going to mutate itself out of existence, because that's not how viruses work, evolution-wise. But just because there is some genetic difference between 2 viral particles doesn't mean that you're developing a totally new dangerous strain of the virus.
We have another question, kind of looking at grandparents. I mean, Debbie, you said that expanding your cluster or your nucleus a little bit. Actually, one of the questions says, Dr. Schwartz, do you see your grandchildren? So maybe you want to answer that, and then also we can talk about a little bit. Should you expand your nucleus? I mean, how much do you have to trust the grandparents? I mean, let's say Joe, maybe answer if you see your grandchildren. And then
I
yeah.
have there. We have communicated from 6 feet apart. I see them on FaceTime, but no, I've not gone into the house. Am I allowed to come into the house?
No. No. So I do not recommend that. I personally, okay. So first of all, I'm obviously in a a little bit of a different scenario because I am a vector risk, a constant one, whereas other people who have been socially isolating for a prolonged period of time and have not been exposed to coronavirus, they, I would feel much more comfortable with them having their grandparents come over. But for me, I think that it's definitely just too risky. It's so variable. I think that if the grandparent is immunosuppressed in any way, it depends on the age of the grandparent. You're definitely there's risk, there's inherent risk. But listen, at the end of the day, you're not going to see your grandchildren for the next 2 years until hopefully a vaccine is invented. I mean, let's be realistic, and I think that this is an important. This brings me back again to the amount of collateral damage that comes from COVID, and our world, unfortunately, when my dad opens this, he talks about how COVID is all we talk about, it's all we think about every day, and it's been going on like this for 2 months, but trust me, there's lots of other issues going on now that are not COVID and that they are getting shoved under the rug or they are getting ignored. And this is so dangerous. And in my opinion, this is what's going to be the big killer in the grand scheme of things. People are coming into the emergency room, when they're waiting way longer at home. So the acuity of the disease is so much more severe. There's been an increase in domestic violence. Interestingly, there's been a decrease in child abuse reports, but I think that that's simply because about a quarter of the reports come from teachers. And guess what? These vulnerable families, these vulnerable children, they're no longer in their safe places. So I think that we're going to see the effects on our kids going forward. Studies have shown that during World War II, when the kids lost, for every year of education loss, there was a 10% reduction in their income, when they're older. I think that there's just so many effects of COVID that we have to stop ignoring.
Well, Debbie and her husband sent over to me a sample of pulled pork.
Don't tell my sister.
What did they send? A sample of what?
Pulled pork, which I guess Josh made. And I'm not going to be scared to eat this. And I bring this up because, of course, this is a question I get so often about food being delivered. And my friend brings me food. Should I worry about it? There is zero evidence of anyone ever getting sick from this particular virus being transmitted by food. It just doesn't work like that. This is a respiratory virus. Even if it's in the food, it goes straight down the esophagus. It's metabolized in the stomach.
But the thought of that is too much.
What?
Thinking about it is hard. Thinking about that, like eating the virus, if it was on food.
Yeah, listen, a lady calls me today, and she says that she gets her baguette, and she brings it home, and she immediately puts it into the oven to kill any virus that may be on the baguette. This is absolutely ridiculous. And then she follows this up by telling me that she takes her morning newspaper, and she puts that in the oven too. And she wanted to know how long you have to put your morning newspaper in the oven to make sure that you're not going to catch COVID from it. This is absolute nonsense. In fact, put that newspaper in your oven, you're going to release a lot of toxic stuff from the ink. And I would really worry about inhaling that.
But can I ask you, but again, this is...
Newspaper in the oven, Emily.
Okay, I won't put that wasn't me. Yeah, we stopped our paper, but I do though have a question because I at some point really want to go. I miss getting a coffee. I miss going to Starbucks. I really miss that. So this past weekend I was like, I'm going to do it. This is a reality or whatever. So then I went into the store. I called them ahead and I said, I'm outside. I'm going to walk in. can you prepare this? How are you? Are you wearing? You're taking precautions? Yes. And I have to say, nothing has changed in Montreal and Quebec now versus 6 weeks ago, because our numbers are still the same. The fact is, things are reopening, but the difference is that now businesses kind of adjusted their way of doing business. So that makes us feel better with the red, X's and where to stand and all those things. But I saw that they were wearing gloves, and she told me she was going to be washing her hands, but she was not wearing a face mask. So again, you're talking about something with the food, passing with the food. And I placed my order and I said, you'll be wearing gloves though, right? Or you'll be washing your hands. And she said, yeah, for sure. And I said, and what about the face mask? And then she said, no, we're not wearing face masks. And then I took a second and then I said, I can't do it. I can't do it. And so I walked out of there without my coffee. And then I thought to myself, should that have made such a difference? Because I know other coffee places are doing that. And whether it's peace of mind or something, and they're touching, the cover. I also wasn't going to have the cover. I was just going to use the cup. Ingesting the food, but I'm busy putting my lips on the cover that they're preparing with. So
you don't have to worry about putting your lips on that, because you're not going to catch this through your drink or through your food.
So ingesting doesn't equal respiratory.
That's right.
And I suppose unless you inhale your food, I guess in theory,
I've been known to. My husband would say that I inhale my food.
Yeah. I do. I mean, I think that, face coverings in places of food. I mean, Starbucks does carry food, so it would make sense that it would be mandatory to wear a face mask. I do agree with that. And
the glove business is also a curious thing, because you can be wearing your glove and you touch your face with the glove. The stuff is still there on the glove. It's no difference.
We saw food delivery people that literally were holding the bags and doing everything great, and then he's opening the door, and then he's taking his phone out of his pocket, holding the glove. I mean, that is not the point of the glove. So it's almost better to wash your hands. And
as a matter of fact, glove wearing has been. Studies have shown that glove wearing actually leads to more contamination. So I definitely don't. People ask me about gloves, and I say it's a hard no. Okay. There's actually an interesting video on YouTube that I had watched of a woman wearing gloves, and then she puts like a little bit of paint on her face, and then it shows how she contaminates herself completely with her gloves. Her gloves end up completely full of paint, and her face and her arms as well, her phone, everything. So it's an interesting video to watch.
Any more questions, Emily?
This is someone, she says she apologizes for not being science literate. But I think it's interesting because, Joe, you'll like to talk about the GMOs also here and genetic modification. Maybe you want to talk a little bit just about vaccines. We've talked about this with Brian Ward, and I think Paul Offit, just how it's developed, because it says a vaccine is being developed by modifying the DNA of the virus. Is it safe? If eating GM food is not recommended, then what about injecting a genetically modified virus? Can it cause bigger harm if it mutates? I apologize if my question is dumb. So I think that's not a dumb question, because that is what we answer here. And I think Joe might want to talk about that, and also GMOs and how they are not dangerous for you.
There's no such thing as a dumb question. I mean, if someone really doesn't know and is eager to find out, it's not a dumb question. But this would require a pretty long lecture to talk about GMOs. There is no issue about GMOs in terms of health. The food GMOs we're talking about, there's no issue. There are some economic issues, some social issues, some political issues, but there is no health issue there. Now, with the vaccination, look, any time that you do anything to the body, whether it's a medication or a vaccine, there always is some risk associated with it. And this is why it is going to be so critical to test the vaccines that are being developed. And there are a number of vaccines that are being developed. There are over 100 companies working on this. And there already are dozens of prototypes which hold out some potential. And when you talk about having a vaccine available in about a year, what they're talking about is having one available to be tested. Not that it is going to be ready within a year for distribution to the public. As you mentioned, any time that you inject into the body any novel substance, there is a risk. And vaccines do present some risk. So it's going to have to be tested. And that testing is not a day, it's not a week, it's not a month, because you may not see the effects for quite some time. So until we are going to have a vaccine that has been shown to be safe and effective is going to be a very long time. We're talking years for this. And there's not going to be one vaccine. First of all, because no one company is going to be able to produce vaccine to use on billions of people. There are going to have to be many different companies producing the vaccines. So I don't know, Jonathan, you want to add something to that?
Yeah, I can maybe disentangle where the confusion lies with the sort of modifying the DNA of the virus. So this coronavirus does not have DNA; it's an RNA virus, but there are similar molecules. What many of the vaccines that are being developed, the way that they work, and the reason why DNA/RNA gets into the picture, is that instead of giving people the virus that is inactivated, or giving a part of the virus like the protein or sugar that is associated with the virus, what a lot of these vaccines that are being developed, what they're doing is that they are giving people a small part of the RNA, so the genetic material of this coronavirus, and they are putting this into a bit of a vehicle, if you will. And inside, once this gets inside of our cells, our cell machinery will take this and will make the viral protein, and that will trigger an immune. I mean, that's the hope, that it will trigger an immune reaction. So these are RNA-based vaccines. So they are not. The vaccine does not change the virus itself. The vaccine is essentially a small part of the genetic material of the virus, so that one of the protein, the spike protein at the top of the virus, will be made inside of our cells, will be recognized as foreign, and will train our immune system to develop a good, solid response against it, so that when you do come into contact with the coronavirus, your cells will remember it and will mount an attack very quickly.
Very good. Unfortunately, and throughout history, there have been vaccines that have been developed that had to be put aside because they either were not effective or they resulted in very significant side effects. So developing an effective and safe vaccine is very, very challenging. And I think we have to be careful not to put all our eggs into that basket. There also has to be a lot of work on developing medications that can control the symptoms and treat the disease. And I think that the chance of having something effective along those lines, I think, is more likely than the development of a vaccine in the near future.
Well, isn't that that's the HIV, like that would be the case of HIV and AIDS, correct? That there's no vaccine, yes, but there's a treatment.
For 35 years, they've been trying to develop a safe, effective vaccine. But there, I do see my grandchildren.
There you go.
See?
Even the dog.
All the grandchildren.
We're missing one.
And they're all there, and I see my grandpup as well. And there they all are. So this is the way I really do get to see them, and I to everyone.
They look like clones.
Yes, they do.
Debbie, have you perfected human cloning?
That's Shiloh. And there's one more. One more is you stick your head in there.
Stick your head in. There you
go. And there in the background is Samson. Holding Samson is the man who pulls pork.
We actually have someone that says, don't leave your pulled pork out of room temperature. It's going to get too much bacteria on it.
Yeah, well, that's a bigger concern than the coronavirus.
But I have to say, there's a lot of comments on my coffee example, because I think people do resonate with that. And just I know we're going to wrap up, but they did say, I mean, basically, someone could sneeze on my coffee lid and I won't get COVID, but someone could sneeze in my face and I could get COVID. And I guess that's the aerosol component and the droplets and everything. And I guess that's the risk one takes when getting a coffee in this time, right?
Yes. But the acrylamide in your coffee is a bigger worry.
Okay.
We'll get into that. Okay, so that's about it. We're running out of time. I think we covered a lot of interesting issues. I had a chance to meet my grandchildren and get face with them. And we'll be back again next week. And talk
bye.
Thank you.
And I tell you, the only thing that we can predict is that it is unpredictable. Because who would have predicted that today we would have this warning about this which everyone is going to be talking about tomorrow.
Yeah.
So you can never predict what is going to happen. This virus is inherently unpredictable. So I can't tell you exactly what we will be talking about next week, but I can assure you that there will be something that we haven't even thought about today. Okay, so thanks very much for being with us, and we'll see you next week.
Thank you. Bye.